We in Nottingham are leaders in monitoring the brain, but we need to think a little bit further down the spinal cord into the brain stem to think about nociceptive monitoring, which is a new and emerging technology. There's been nociceptive systems on the market for some time now, largely based on the pupillometry or heart rate variability, but I want to introduce you to a system called the null, the nociceptive level monitor, which combines multiple different sympathetic parameters to give us an index of nociception. And I'm delighted to be joined by Rachel and Joella from Medisense, the company who've developed this, to give us an overview of the technology over the next half hour before I show you some clinical cases and talk about how we're going to move forward and evaluate this technology at NUH. So Joella and Rachel, I'd like to hand over to you, please.
All right, brilliant. So thank you very much to for the opportunity this morning to introduce you all to null. I joined Medisense 4 years ago. I lead clinical and regulatory activity at Medisense. We're a company based in Tel Aviv, Israel, and delighted to start this talk by just touching on the agenda. So obviously I'd like to first introduce you to the technology and then talk about the clinical value proposition and some highlights of the clinical evidence generated to date using this monitor. And then I'll hand over to my colleague, Joella Taylor, who leads our education and marketing efforts at Medisense. And she'll take you through some examples about how we actually use null in clinical practice. And then it'll be back to Mark, who will give some additional case reports based on his work with the device over the last year or so. So off we go. So introduction to null technology. Well, we have to start by talking about the challenge. And as I believe that most of the audience today is anaesthetists, of course, you're all very familiar with the triad of anesthesia. And we've had monitors around for years for monitoring muscle relaxation and also monitoring the depth of anesthesia, the effectiveness of the hypnosis. But with nociception to date, we haven't really had a dedicated monitor. So nociception has been assessed indirectly through changes in heart rate and blood pressure. But the challenge is that heart rate and blood pressure are not really specific or sensitive enough. And as a result, patients may be provided with either inadequate or excessive analgesia. So why does this matter? So we know that patient variability is huge, and there's also wide variation in clinical practice, where there are many types of anesthetic regimens using multiple drugs to offer anti-nociception. And as to patient variability, I believe that at least all over the Western world, we see with the increased longevity, there is a lot more, there are many more patients who are ASA3 and ASA4. So we have more elderly patients and also more patients who are obese or opioid tolerant. And all this leads to a very large interpatient variability in the metabolism of opioids. And a lot of this is related to pharmacogenomics and really the activation of the mu receptors, which is very different in different patients. And as a result of all of this, we can see studies have shown that there is up to a 30-fold variability in the interpatient variability in plasma concentrations of opioids. And it's true that most of the patients may be in the middle, which we can see here in the middle of the Gaussian distribution. And for them, probably calculating the dose according to weight may be sufficient. But today, clinicians are faced more and more with the need to treat the outliers, these elderly patients and who are fragile, who require lower doses in order to achieve the same therapeutic effect and maintain their safety. Whereas we have the patients at the other end, the patients who are opioid tolerant or the patients who are obese, whose metabolism is also different and will require a different dosing. So really what we're talking about is the need for a monitor to understand the drug's impact per each patient and to be able to do truly personalized dosing according to their needs. And if we don't have an objective guide that is helping us really optimize the dosing, the patients can end up suffering suboptimal pain management, or more correctly, management of the anti-nociception during surgery. So let's dive a little into the actual technology. Null technology. Well, when we experience a noxious stimulus, the sympathetic nervous system is activated, and it's associated, of course, with the fight or flight response, and this results in a constellation of physiological responses. So the technology we built, recognizing the complex nature of pain, uses a multi-parameter-based approach to detect and quantify both nociception and to measure the analgesic effect. So essentially, what we are trying to monitor is the nociception anti-nociception balance, intentionally not using just one single parameter, but a constellation of them. So the technology is non-invasive. All the signal acquisition is off the finger. We have two main sensors, which are the photoplethysmograph and the galvanic skin response. From the photoplethysmograph, we get pulse rate, we get pulse rate variability. We also get the PPGA, the photoplethysmograph amplitude, and also many more derivatives of these main parameters. From the galvanic skin response, we actually get we get the sweat level through quantifying the electrical conductance, and we measure the peripheral skin temperature, and we have an accelerometer to quantify movement. The skin temperature and the accelerometer are actually supporting parameters. The core of the algorithm, which I will explain in a couple of minutes, is based off the parameters that we get off the photoplethysmograph and the galvanic skin response. And again, all of this is obtained using the finger probe that you can see here. You can see that there is a white kind of pad there, which is a single-use sensor attached to the base of the finger. And that is allowing us to capture the galvanic skin response. The other three parameters, the other three sensors are actually in the red finger probe. And the probe is attached to the patient's finger. And as you see, it looks a bit like a pulse oximeter. So we capture all the signals off the patient's finger, and they are then delivered into this bedside monitor, the PMD 200. And what we get on screen is a numeric. You can see that on the right. That's an index providing an objective personalized scale. 0 has been shown to be no nociceptive response, and the scale goes up to 100, extreme nociceptive response, and it's based on artificial intelligence technology, which essentially allows the index to be personalized to each patient. So a measurement of 25 on me would not be the same as a measurement of 25 on Joella, and we'll get to that in a minute. In addition to the numeric value that you can see on the top right-hand corner, we also have a trend, which is displayed over time. You can see this. You can see this below, and the trend is very, very important because actually our clinical decisions on how to use the monitor are based on responding to the trend, and we'll get into that. So if we want to summarize how we work, we start with the signal acquisition using the non-invasive finger probe. It's acquiring multiple pain-related physiological signals through 4 sensors. And then we have dozens of pain-related physiological parameters and derivatives that are then extracted from these signals. They are then normalized to a database that is preloaded on the monitor, which includes tens of thousands of data points. And then what the monitor does is analyzes all of this information that it's being presented with, and it determines the patient's real-time and continuous physiological signature of pain. So as now I'm speaking to an audience of anaesthetists, I know I can use the term nociception and anti-nociception balance, and the term will be understood. But sometimes when we use this term of nociception, anti-nociception, people don't really understand what we mean. So we talk more about the physiological signature of pain. After the algorithm essentially looks at the patient's patterns and compares them to a pre-installed database, it is able to establish a personalized signature of pain for this particular patient, and then it presents it on a scale of 0 to 100. Through this process of pattern recognition and normalizing it to this existing database, we end up with a personalized signature, and this is why at the end of the day, my value of 25 represents an ideal value for myself, and another patient's 25 could be different, and it represents their relative 25. So it's a personalized scale. It's always presented on a scale of 0 to 100, when 0 is no nociception and 100 is extreme nociception, but it's personalized to each particular patient. I just mentioned the number of 25. Our clinical work has shown that 25 is an appropriate threshold, distinguishing between nociception, no nociception, and nociception. This threshold was established through data that we collected while using the device in clinical practice. So obviously the first stage is actually to develop the device and to start using it. But in order to actually find a way to use it meaningfully in clinical practice, we have to find the right threshold. So with the BIS monitor, we know that the appropriate thresholds are 40 to 60, and the goal is to stay between 40 and 60. With pulse oximetry over the years, it's become clear that 90 is typically considered mild hypoxemia and 85 is considered severe. With null, what we did is after the initial building of the device, where we looked at different types of noxious stimuli, for instance, intubation and incision and so on, and also periods of non-nociception, we landed around 25, but then we needed to actually validate this. So we validated it by deriving the Uden index from ROC curves. So meaning essentially that we had a verification cohort and a validation cohort. And we looked at the sensitivity and the specificity based on these predetermined annotated events. And we're able then to derive the Uden index, which showed the best transition point between adequate nociception, anti-nociception balance and uncontrolled nociception. Once we established this threshold of 25, it was clinically validated in controlled studies. So there were studies done in Leiden University, Medical Center in the Netherlands. These studies were done both in TIVA-TCI regimens with remifentanil and propofol, and also with volatile anesthesia combined with fentanyl. And we were able to show in both of these studies that when 25 was used as a threshold, indeed, the patient outcomes were improved, be it through reduction of intraoperative remifentanil or reduction of postoperative pain. And then after doing these controlled studies, we also did a retrospective study in 447 patients, showing that this threshold of 25 is generalizable to different types of cohorts. So we're essentially showing that null was agnostic to different types of patients or anesthetic regimens, and 25 was found to be a consistent threshold. So null, of course, is indicated as an adjunct monitor for use by anesthesia providers. So it's meant to add information. By no means is it a replacement for the clinician's own judgment and for the use of other monitors. We have developed several types of materials to help guide clinicians in the implementation of the device in practice. So we have a null pocket guide, we have a white paper explaining the algorithm, and other types of training materials. We also have a lot of materials on our website and on our YouTube channel. So just to show you a little bit more about this threshold of 25, So this is an abstract that was presented at the PGA meeting in New York a year ago. We currently have a manuscript developed that's currently under peer review, developed with the team at the Cleveland Clinic. And the idea is that we took 447 patients and we did a subgroup analysis. We looked at patients based on dividing them by age, over 65, under 65, by sex, male versus female, by BMI. So we had normal weight patients, overweight and obese patients, by ASA status, ASA 1, 2, and 3. And also according to analgesia and anesthesia regimen. So remifentanil versus fentanyl, and desflurane compared to sevoflurane and propofol. And what we did is we took all these, we took the annotated data points that we had in these 447 patients. We had annotated events for intubation, for incision, trocar insertion, and also non-noxious events such as draping or blood pressure measurement. And all of these events were annotated by clinicians in clinical studies that we had done in order to actually build the technology, and also in some of the initial validation studies. And we took this annotated data and we had these different types of events that were either defined as highly noxious, as medium noxious, or as non-noxious. And what we wanted to understand is whether the performance of the device would be consistent in all these different cohorts. So for instance, if we look at the top left corner with the age, so we can see that on the left we have the response. Response of null to non-noxious stimuli, and we can see the box plot representation of all the response to all these different types of non-noxious events. And we can see basically when we look at the box plots, we can see that the null values are very low. There are a few outliers which are above 25, but the vast majority of the points are well below 25, just as we would expect. And on the right-hand side of the age box, we can see that when these patients were subjected to noxious stimuli, such as intubation and incision, we can see that the median values are above 40, whether the patients are under 65 or over 65. And in general, the vast majority of these values are over 25, as we would expect. And then the same logic holds for all of these other subgroups, and we see a consistent performance. Basically, the most important point here is that we see that the null number is agnostic to the different patient demographics and anesthetic approaches. If you look at all of this description on the graphic to the left, well, the main message here is that there's no difference. Everything looks the same, and the null is not impacted by the type of analgesia, anesthesia, ASA, BMI, age, and sex. That it distinguishes between noxious and non-noxious stimuli in all of these subgroups, and that 25 is always an appropriate cutoff point. But this is really important because, for instance, with depths of anesthesia monitoring, we know that when we use processed EEG, the response to different types of certain anesthetic agents can be prone to artifacts. We don't need to discuss this in depth, but obviously the response of the BIS monitor to agents like ketamine, magnesium is atypical. So it was really important for us to be able to properly establish that the performance of null would be generalizable to different patient cohorts. So just moving on. As I mentioned, we have developed a lot of assets explaining the technology and explaining how to use it in clinical practice. It's all obtainable on our website. I do encourage you all to please take a look at our website. There are many lectures there. Take a look at the scientific documentation we've created. It's really important for us that our technology is transparent and understandable. I'm not going to explain the machine learning in full at the moment because it's not something that we can achieve in this timeline. But if there is further interest, I'd be happy to do a deeper dive into the technology. Just about the validation journey we went through. So as I mentioned, our assumption is that null would outperform other monitors in detecting and discriminating between noxious stimuli intensities compared with commonly used parameters. And this was a study that was published in Anesthesiology by Chris Martini and his team from Leiden. And essentially what we can see here is this logic of taking annotated events in 70 patients under general anesthesia, undergoing intubation, incision, and non-noxious events. What the results show us is that the bispectral index is not a nociception monitor. Heart rate responded better. MAP also responds to, of course, to noxious stimuli such as incision and intubation. And each of these little graphics, we can see the response before and after the stimulus. So when there's a non-noxious event, you see no change before and after. And when there's a noxious event such as incision, or an even stronger event such as intubation, which is recognized as a literature as the strongest as eliciting the strongest nociceptive response, we can see a bigger difference. But null outperformed heart rate and MAP, and null was the only monitor that correctly scored the level of nociception intensity, with intubation showing a stronger response than incision, which in turn showed a stronger response than non-noxious stimuli. So there was some response with heart rate and MAP too, but it was only null that showed this differentiation in a statistically significant manner. In a second validation study that was also published in Anesthesiology, null outperformed heart rate, PPGA, and SPI. SPI is another nociception monitoring technology that was introduced by GE. And it showed the best ability in discriminating between noxious and non-noxious stimuli with an ROC of 0.93. Now onto the value propositions. So we have a validated technology. So what are the benefits of nociception monitoring? So we have multiple areas that we have been studying, and as with any new technology, when we introduce it to the market, we need to work very closely with the clinical community in order to really establish how this device could actually make a difference as an adjunct monitor. And what we've been able to show so far in studies is improved patient outcomes through reductions in post-operative pain, and also reducing stress hormone levels during and after surgery. That was shown in one of those studies from Leiden. With remifentanil in particular, with null, we have personalized opioid dosing and leading to fewer hypertensive events as a result of optimizing the remifentanil dosing. Null can be used to confirm the effectiveness of regional anesthesia. So this is important with epidural to ensure that the epidural is indeed delivering the expected therapeutic effect. And confirming the effectiveness of regional blocks. So regional blocks are often used, for instance, in shoulder surgery, in thoracic, the mainstay in thoracic surgery, using the paravertebral blocks. And null can really visualize to the clinician, confirming that the block is working as expected or not working. We can offer safer analgesia in high-risk patients. So we talked at the beginning about these patients who are outliers, the ones who are frail, elderly, obese, or opioid tolerant, for whom the typical analgesia dosing, which is weight and age-based, may not suffice. And also confirming the effectiveness of multimodal analgesia and opioid-sparing regimens. And Mark mentioned in the introduction the linkage with OFA2. OFA2 with opioid-free analgesia, we still need to really develop the evidence, but the logic is the same. We have an objective non-invasive monitor that can help quantify whether the opioid-free analgesia regimen is actually working. Just quickly to touch on a couple of the studies before handing over to Joella in respect of the time. So we have some controlled studies. This is a controlled study, again, published by the team at Leiden, led by Albert de Haan. comparing, this was a controlled study in which in the standard of care group, it was clinician judgment used essentially to guide fentanyl dosing. And in the null guided group, this in major abdominal surgery, the fentanyl dosing was guided according to the null. If the null was above 25 for 1 minute, a bolus of fentanyl was given. And if the null was below 25, no fentanyl was given. And in the null guided group, there was a 33% reduction in pain scores in the PACU at 90 minutes. So the median pain score went from 4.8 to 3.2. And there was also up to 50% reduction in stress hormones. So we know, of course, that stress hormones are not measured in routine clinical practice, but it was interesting to see the potential mechanism of action that the patients were actually experiencing less surgical stress, as evidenced by lower secretion of stress hormones, both during surgery and in the PACU in the null-guided group. There was also, the study from Leiden was then repeated again in Israel by a different team. They got very similar results. They got a reduction of 1.5 in the pain studies, in the pain scores. And when the Israel study and the Leiden study were combined, we got a larger sample size, which allowed us to do further analysis. So with a sample size of 125 patients, we saw when we looked at the patients' pain scores in the PACU, you can see with your, just by eyeballing, you can see that there were far less patients reporting severe pain in the null-guided group. And when looking at the explanatory factors that could explain this difference in severe pain rates, null was the only significant factor explaining the difference. So there was an odds ratio of the odds ratio for experiencing severe pain was 6 times lower with null guidance, and this was the only factor explaining it. Obviously, severe PACU pain is something that we seek to prevent. It's associated with negative clinical outcomes. When patients have severe pain, they're typically treated with opioids. And as I mentioned, age, sex, BMI, type of surgery, and the ASA risk score of the patients did not explain the difference in severe pain. The only factor explaining severe pain was the use of null to guide analgesia. And then another study was done with remifentanil and propofol, and I believe that you use a lot of remifentanil at your centers. What was shown when null was used to guide remifentanil dosing was a 30% reduction in remifentanil use that also corresponded with an 80% reduction in hypertensive events. So personalized intraoperative remifentanil dosing with null also led to meaningful benefits. And a meta-analysis was recently published on nociception monitors. This was 21 studies, 1,957 patients, 201 of them were null monitored. And the primary endpoint of this meta-analysis was reduction in intraoperative opioid administration. And indeed, that's what they showed with the key results, that the intraoperative opioid administration was reduced, and this led to further benefits. So at this point, I'd like to hand over to Joella to take us through some of the tips and tricks for implementing null in clinical practice. Joella?
Thanks, Rachel. And let me know if there's too much background noise, and I'll. So I'm just in the OR today, so difficult to get a quiet room. But I'll speed through this because I know we don't have much time. So what you can see on the slide here is a bit more of a description about how we interpret the trend. So in clinical practice, when there is a value of null above 25 for more than 1 minute, that is indicating that the patient is experiencing significant nociception and therefore requires additional analgesic therapy. So depending on your analgesia, then either you would increase your concentration of remifentanil or perhaps give a bolus of fentanyl. On the other side of the coin is the too low levels of null, and that's when it's very close to 0 for more than a minute, but that's only when there is significant surgical stimulation occurring. Of course, if there's no event happening, then we would expect null to be very low. Another caveat to that is that if you are doing null in a combination with a regional block, then very low null values are expected, and it's not a cause for concern that null could be close to 0 if the block is effective. But the ideal values that we want to see are the range of fluctuations between 0 and 25, which is indicating adequate nociception, anti-nociception balance. So that's the area in the green that you can see there. And that is always what we're going to strive for. Of course, everything really depends what else is going on clinically. So you may see a jump, and that's what I'm going to show in the next few slides in a moment. But of course, there might be a slight increase in knowledge. Let's say ephedrine is given, or noradrenaline. So you always need to be aware of what other activities are going on at the same time. And of course, if fentanyl is the analgesic, then there's not much we can really do if null is very close to 0, because fentanyl is a longer acting opioid than remifentanil. So again, everything needs to be done in consideration with the drugs on board and what's happening with the patient. So what we try to do in the next few slides is just give you, these are all fictitious scenarios, but based on real cases, to just give you an idea of the expected trends that you can see during a case with null. So this is an example of a bariatric case. You can see on the screen the initial hemodynamics. And this patient was treated with a general anesthetic along with an epidural as the main analgesic. So what you'll see on the screen at the top is just a graphical representation of the changes in null and bis. During induction, in the red, you'll see null, and in blue, bis. So during induction, as the anesthetic agents are given, you'll see a decrease in both bis. I know if you do use bis, you'll probably be used to perhaps lower values than what you can see on the screen. This is just a representation. And also, as the sympathetic reactions are blunted with the anesthetic, then of course there'll be a decrease in the null in the red that you can see as well. But what you can see in the peak here is usually what you would tend to see during intubation, which could be one of the most painful stimuli during the case. So this sharp increase in the null can sometimes reach to levels of, here you can see around 70. It doesn't always go as high. It of course depends on the intubation technique as well as other factors. And at this point, there's not really much you would do. You of course understand that the steep increase in null is due to the intubation and will hopefully decrease. But interestingly, what we can see in the hemodynamics is there isn't really much change during of the heart rate or blood pressure during the intubation. There was maybe a slight increase, but nothing of significant concern. So it's really trying to show you that there is quite a big difference between the standard parameters that we would tend to look at as indicators of nociception and what the null can tell you, which really helps when it comes to decision making. What you can see here is during maintenance, sometimes there can be an increase in the null, and again, not much change. There was no real change in the bis, and we can see at the beginning that null was pretty low, which would indicate that the epidural was very likely effective and in place. So in this situation, it probably could be that the surgeon was operating in an area that was above the epidural level, so not covered by the block. And in this situation, you would maybe want to either give an extra bolus of fentanyl, or depending on your analgesia regimen, perhaps increase the REMI.
Oops, sorry.
It's okay. Well, I'll jump through anyway because we are running out of time.
Yeah.
So sometimes you'll see an increase in null, as I mentioned earlier, that is not due to nociception. In this situation, it could be, for example, by administering ephedrine, which will cause an increase in the hemodynamics, which would be reflected in the null, because those are the parameters that null is looking at. And during emergency and extubation, there's not much that you would necessarily act upon based on the null, because you're coming to the end of the case. But just to demonstrate, what you would tend to see is that as the anaesthetics are wearing off, you'll get that general increase, gradual increase in both BIS and null as the sedation and analgesia are stopped. We also just wanted to give you an example on the next slide of from a different case of when I mentioned before how null can help with decision making, is that occasionally you'll see that the null and BIS and HOT and everything else could be in range. As you can see, the null there is pretty low. However, there can be an increase in blood pressure, and without null, perhaps the interpretation of this may have been to administer additional analgesia, because there isn't any other indication, perhaps, of what could be causing this high blood pressure. But with the null, you can be certain that it's not due to nociception. In this situation, administer a calcium channel blocker instead of additional analgesia. So it really kind of helps with your decision making and deciding what is happening with the patient and what analgesia or other treatment therapy to administer to the patient. I think there were a couple of, I think that's the end of what we just wanted to show you again, just to give you a brief overview of everything. And just to summarize, the whole challenge of that we're here to solve is the issue of titrating analgesia during surgery. And this is really made difficult by the variability between patients, because not one patient's needs are the same. And without an objective guide, patients can suffer suboptimal pain management. So what we are doing with the null technology is providing an objective reflection of the patient's nociceptive state. We are really giving you a window into what that patient is experiencing during that specific time frame. And based on the clinical evidence that Rachel has described, and we're more than happy to send you our full list of publications and answer any other questions you might have, we have shown in our outcome studies that null monitoring compared to standard of care monitoring can help reduce postoperative pain, reduce remifentanil administration, and the incidences of hypertension. And there's several different, there's a lot of potential for null and many different types of surgery and types of patient, but of course the most useful patient groups would be those who are atypical of the general population, for example, elderly, frail, obese, chronic pain patients, and opioid tolerant patients. And the best way to get familiar with null, of course, is to have a look at it for yourself. So thank you so much for everyone's time and attention. And I guess we'll hand back to Mark now.
Well, thanks very much. I'm going to very quickly run through some clinical experience that I've had with the technology that I've been using now for a wee while now. We've got a couple of these monitors which are going to be available for trial at NUH, which I think is quite exciting, one on each campus. So very quickly, just to remind you, of course, anaesthesia and surgery is a very dynamic state. We expose our patients to a variety of different stimuli, all the way from intubation, which is a supramaximal nociceptive stimulus, all the way through to incision and various other bits of poking and prodding that cause our patients to manifest a positive null response. Now, how can we decide how much opiate we should give intraoperatively? Well, we can use guesswork, we can try and use finger on the pulse, we can use our knowledge of pharmacokinetics, pharmacodynamics, but actually the things we're traditionally using, heart rate, blood pressure, as both Joella and Rachel have emphasized, aren't particularly sensitive nor specific when compared to the multiple parameters that the nociceptive monitor is measuring. And indeed, here's the receiver operating curve for null, which demonstrates a far larger area under the curve, so greater sensitivity and specificity than the traditional techniques of blood pressure change or heart rate. Really, what we're interested in isn't what the BIS monitors can pick up, hypnosis, but we're actually interested in what the brainstem's doing here in the medullary autonomic circuit, which is producing those changes in heart rate and blood pressure. And the multiple parameters that the null measures is giving us this an indication of what the brainstem is doing in response to the nociceptive inputs, which our surgeons are creating. And even with increasing amounts of remifentanil, the BIS monitors aren't able to tell us how the nociceptive response has changed. If you look here, the BIS is this blue line, the blue line, with increasing dose of remifentanil, there's no real change in BIS number in response to a nociceptive stimulus, in this case, tetany. So what do I think about quantified nociception? Well, I think we've got an opportunity here to reduce inter-anaesthetist variation in pain management. What I might do in response to an increase in blood pressure or heart rate might be very different to the anaesthetist in the theatre next door. Indeed, what parameter would we use? What change in heart rate? What change in blood pressure? So we're all doing something a little bit different, and being able to quantify nociception gives us an opportunity to align our practice between anaesthetists. And we can quantify the stimulus and response of what the surgeons are doing and become more attuned to the variation in surgical stimulus. And we can standardize our documentation and decision making. And perhaps when we want to change our analgesic strategy, we've actually got a quantitative method to be able to prove the superiority of changing a drug, adding a lignocaine infusion, using some clonidine, for instance. What difference does this make? Well, we can identify this by looking at the area under the null curve. We plot the trend, and this is something you can export from the monitor in .csv format, have a look at in Excel and see the real difference that you're making to the patients by changing your strategy. And of course, it's useful in tricky patients, the morbidly obese, the opiate user, chronic pain patients, and the very frail and elderly who've got a very diverse response to our anti-nociceptive drugs. I think this is going to be really valuable in major thoracic surgery, major general gynae and vascular surgery, any point really where we're using epidural analgesia, spines, where multiple analgesic modalities are used simultaneously, including ketamine infusions, and of course, where there's a block plus the GA. But I know that most of our regional anaesthetists are so good that a GA is an exception rather than the rule. But for some of us mere mortals, as a way of demonstrating block efficacy, a null system can be valuable. So there's a few caveats, though. You do need to have a good SATS probe trace, of course, to produce the photoplethysmograph that the device needs. So it's not it's very useful in a patient who's profoundly septic and hypotensive, but that's a surprise, not really a surprise, is it? Because it'd be difficult to measure changes in blood pressure and heart rate from a nociceptive point of view in those patients anyway. As you might imagine, any system that relies on cardiovascular parameters is going to be influenced by drugs which affect cardiovascular parameters. No surprise, a drug that increases your heart rate will increase your null value. A drug which increases vasoconstriction with a consequence reduction in heart rate is going to reduce your null value. And I'll show you an example of those. So some clinical cases. I've been fortunate to anaesthetize the same patient twice, 3 weeks apart, once with null and once without. So on the left-hand side, this is a density spectral array, of course, from the narcotrend system. And I was using my common sense and clinical acumen to dose the remifentanil and propofol in this patient for a microlaryngoscopy. He came back, and this bit of the trace is demonstrating his panendoscopy before he went on to have a laryngectomy. But using the null, I was able to significantly reduce the amount of remifentanil I was using in this 77-year-old man. And we can see that the alpha band, this higher red band here, is much, much thicker. I'm not suppressing his brain function quite as much when I'm using the null to optimize my remifentanil delivery. So I was very confidently able to reduce the amount of remifentanil I was using, and at some points even turn the remifentanil off during the doldrums where there was very little surgical activity. And that's helped me to learn a lot about the pharmacodynamics of some of the drugs that we use. Now, this is a trace from the device here. I put the 25 marker on, and we can see here I've used indicators to show where I've done various things. And as both Joella and Rachel mentioned, one can see a spike following intubation, which rapidly wears off. And at this point, I've decreased the opiate as there's very little surgical activity happening prior to increasing it before a painful stimulus here, which I've managed to keep below the value of 25. And as surgery's progressed, we've seen a few fluctuations, again, below that value that we're trying to maintain below. And I've been able to increase and decrease my opiates in relation to what the patient needs and what the stimulus the surgeons are creating. I've also found that I've been able to improve my processed EEG images, again, by titrating my remifentanil accurately. So here I've lost my alpha band, been able to decrease my opioid, decrease my hypnotic and regain alpha prior to a positioning change, and then optimizing my remifentanil dosing prior to incision. So a decrease following intubation. We see a spike with positioning, and which obviously is non-nociceptive, but can produce a spike. I've increased my opiates here, again, to suppress the response to incision, and then I've been able to titrate following incision my remifentanil downwards again. Now, ketamine, as mentioned, does cause us some mischief, doesn't it? Because it produces an excitatory pattern on the EEG. Here's the response of the narcotrend in a patient who's had a wonderful response to ketamine. This will be 35 milligrams of ketamine, so a subhypnotic nociceptive dose. What we can see is a lower amplitude, higher frequency EEG, which the monitor has correctly detected. But look what's happened on the null monitor. We've seen a rapid fall from an elevated value right down to 1. So there's a very low level of nociceptive response to surgical stimulus, whatever mesh Mr. Catton's putting in here, probably an anterior abdominal wall repair or something like that. But very, very little response here following ketamine. This is what the density spectral array looks like following ketamine. The brain is excited, but the brain stem is not producing a nociceptive response. So this is a device which is agnostic of the analgesic regime. And again, we can see what happens following the ketamine. We fall down to very, very low levels. So the device is agnostic of the analgesic use. This is an epidural, so a laparotomy, incision, no response at all. But the surgeons have started to play down in the pelvis here, below the level of the block. But we always return to a low null level, indicating the epidural was working, but these transient stimuli are retractors going in and out of the pelvis below the block. But we're confident the epidural was working because we've had no response to skin incisions or the operation within the abdominal cavity, and this patient woke up extremely comfortable afterwards, which is gratifying. So clinical correlation of the trend is important. Elderly patients, I think it's very valuable. This is 8 and a bit hours worth of alfentanil and propofol tiva in a poor patient having a temporal bone drill out and ALT free flap. This is what happens when the surgery gets really boring. There's very, very little nociceptive stimulus for the patient at all. I'm able to reduce the alfentanil infusion down to just 50 nanograms a mil, so very low concentrations. There's very little surgical activity. Even the monitor is bored, and the patient waits 10 minutes of stopping the drugs after 8 hours of surgery, which is very gratifying. So this really helps optimize it. You can also use the device to pharmacodynamic opiate dosing. So here I've induced anesthesia, suppressed the responses to laryngoscopy and intubation. I've given a tetanic stimulus here using one of our nerve stimulators and seen a little spike, which has caused me to increase the opiates, which has allowed me to suppress the response to incision. A 5-second tetany is, in pain studies, analogous to knife to skin. So the fact I could use this as a calibration, get feedback and see the effect of my opiate dosing meant that we could confidently be sure that we were delivering the appropriate dose of medication. And again, you see ketamine suppressing any responses to nociception, and how I've been able to decrease and titrate my anesthesia and personalize it for the patient. Vasoactive drugs, as I mentioned, anything that increases heart rate will cause a temporary spike in null index value because, of course, the monitor is using heart rate and heart rate variability as key parameters. But this is transient and lasts about 3 to 6 minutes. So I find that these nociceptive monitors allow us to visualize the pharmacodynamics, better understand the pharmacokinetics, and deliver personalized, optimized anti-nociceptive dosing. We've got loan devices at City and Queen's. We'll put some dates out for teaching sessions where Kerry Davis, our Medtronic rep, will kindly come and do some drop-in lunchtime sessions, but we'll come to theatre with you to assist you in using this novel device. And I'll be very keen to get your feedback in the near future to see whether this is a good fit for anaesthesia at NUH. Thanks, and I'll be delighted to take any questions.